Welcome everybody to our weekly case presentation of our NeoFOCUS group. And today we're just going to crack on. There'll be a recording so people who join later can see the recording. So I'm going to introduce the presenter. So we have the privilege of having the team today from Royal Sussex County Hospital, Brighton. Dr. Praveen Kishore is a consultant neonatologist there who has decades of experience in neonatal cardiology and pediatric cardiology, and has keen interest in neonatal cardiology as well, including hemodynamics and point-of-care ultrasound. He conducts local courses on regular basis, and today the presenter from the team is Dr. Chrysoula Rizava, who's an ST7 great trainee in neonatology, and she has recently completed her spin in pediatric cardiology. So I'm going to let her introduce the topic to you. So Chrysoula, over to you, please.
Hi everyone, thanks so much for having us here. Hopefully Praveen is going to log in soon as well. As I said, my name is Chrysa. I'm an ST7. I'm a great trainee in Brighton. I've recently finished my spin. I've got a great passion for cardiography, and hopefully we'll have an interesting case for you today. I'll start sharing, and then we can start with the presentation. Can you all see my screen?
Yeah, we can, but it's not in presenter mode. Let's try.
1 second.
Perfect.
Is that okay?
Yeah, wonderful.
Great. The title of the presentation is it PPHN? And obviously the first thing we think about when we think about it's not PPHN is obstructed TPVD, and I can tell you that this is not a case of obstructed TPVD. So we'll start off with this is the outline of the presentation. So it's just an overview of the clinical case. So we'll talk a little bit about the background and the birth of the baby and the initial management in the District General Hospital. Then I'll show you some echo clips and how the diagnosis was made, and then we'll talk a little bit about the further management and the long-term follow-up of the baby. And then the second part of the presentation, I will talk a little bit about the condition, and then hopefully we'll have a nice discussion at the end. Starting off with our case. So this is a term baby that was born at 40+0 with a birth weight of an impressive birth weight of 4.985 kilos. She was the family's third child. It was a completely uneventful pregnancy with normal antenatal scans and normal serology. There were no maternal health issues of note, and mum was not on any medications. She didn't have GDM, and there was no family history of note. The history we got was that the week leading up to the birth, mum presented 3 days prior to delivery with reduced fetal movements to her local level 2 center, actually. She had a sweep. She was assessed. The midwifery team was happy with her. She had a sweep and she was sent home. Presented 3 days later with normal initiation of birth and normal progression. The baby girl was born by normal vaginal delivery in the middle of the night. There was shoulder dystocia, so there was a slight delay between the delivery of the head and the body of the baby, but the APGAR scores were not that bad, so 4, 8, and 8. The cord gases were near normal, so PITs of 7.24 and CO2 of 7.9. The baby was active after birth. She wasn't floppy or not breathing, so but she was stimulated she was found that she wasn't saturating well, so they provided FiO2 up to 60% saturation, so around 85%. Subsequent to that, she was admitted to the neonatal unit. So she remained on Optiflow for a period of time in the neonatal unit. She was screened, started on antibiotics and IV fluids. But as the hours progressed, her FiO2 increased up to 8%. She did have an X-ray locally, which showed mild RDS. So the team decided to perform LISA, so gave her the first dose of surfactant. So she was not intubated. After that, the FiO2 requirement persisted, so she was electively intubated. And at that point, when they realized that they were struggling with the baby, they called our neonatal unit in Brighton. So they were advised to treat the baby as PPHN. So nitric was started, lines were inserted. The transport team was called and was mobilized, and an echo team was done. An echo was done locally. So the report that we have from that echo there was that it showed evidence of PPHN with TR up to 3 meters per second. Sorry, it's missing there from the presentation. There was also bidirectional flow at the level of the PFO. Upon arrival in our unit, it was about nearly 24, a little bit more than 24 hours of age. She was intubated and ventilated on PCSC volume guided with 60% FiO2 and nitric of 20. Interestingly, the transport team said that the nitric didn't make any difference in the baby's saturations. The baby was sitting about 90%. She was sedated and paralyzed. We did note that she had reverse differential cyanosis, and the gap was about 8 to 10%. And that's probably an interesting discussion point, which we'll come to in a bit. She was also on inotropes, so she was on dobutamine of 20 and a little bit of adrenaline. She was on IV fluids and on first-line IV antibiotics. So next, I'm just going to show you the clips of the echo that we did that morning. So in the first subcostal view, so we saw that the atrial septum was brought to the left, and the flow was bidirectional. So that was the first warning sign. More interestingly, as we progress through the views, so I'm not going to show you the full echo, so I thought I'll just show you the interesting clips. But so on the 4-chamber view, what we could see was a dilated and hypertrophic right ventricle with a dilated right atrium, and obviously the RV function was not optimal as well. There was 2 jets of mild tricuspid regurgitation. That's from a long axis view, and again from a short axis view. That was the Doppler, continuous Doppler through the tricuspid valve with the velocity of a TR jet of nearly 3.4 meters per second and a pressure gradient of 46 millimeters of mercury, which was about systemic. That is a view of the main pulmonary artery and the branch pulmonary arteries. There was no obstruction. The pulmonary valve looked normal. It's not apparent in this clip, but it was normal. And there was unobstructed flow down to the pulmonary arteries. We did have some turbulence in the LPA. And the other thing that we noted was that there was no evidence of a duct. That was also apparent from the arch view. So again, we couldn't see any evidence of a PDA. So overall, there was no RVOT obstruction. There was no TAPVD. All the veins were seen returning to the left atrium. There was a hypertrophic, dilated, poorly functioning RV with a dilated right atrium and bidirectional flow through the PFO. So I don't know if anyone wants to guess what. So obviously after that, after we got the echo, we discussed with the cardiologist and they gave us a diagnosis, but I don't know if anyone wants to have a guess of what that might have been. Shall I give it away?
Well, I guess there's no duct, so like a premature closure of the duct.
Yes, absolutely.
With a really impaired right ventricle, which is not really going to benefit from that dobutamine and adrenaline that was started.
Absolutely.
So really keen to hear what the cardiac team then suggested. Yeah,
absolutely. So thank you for that. So yes, it was a premature closure of the arterial duct. That was the diagnosis. So we started milrinone and noradrenaline. We stopped the dobutamine to support the right ventricle. We obviously the baby had serial echocardiograms throughout her admission. She remained really well for more than a week. On day 2, she still had raging PPA10 effectively, well, pulmonary hypertension. Prosting was started in an attempt to open the duct, which was unsuccessful. So on day 4, she was started on IV sildenafil, and then following that, she started improving. She came off nitric, she came off the noradrenaline, and on day 7, she was extubated onto high flow. On day 9, she was switched to oral sildenafil, and on day 14, her milrinone was stopped. At that point, we did the second, we did a pre-discharge echo prior to sending her to her home hospital. So I'm just going to go through the pictures there. So this is again a subcostal view, which shows that the atrial septum is still bowed to the left, with the bidirectional flow, which was still evident there. And then, but interestingly, so the we see that the RV, it's in a much better shape now. So there is still right ventricular hypertrophy, but the function is better, and the RV and the RA is not dilated anymore. That's a closer look onto the RV. So there was minimal tricuspid regurgitation there, unobstructed flow through the RVOT, and the final echo picture, an unobstructed arch with no evidence of the duct. I thought I'll just put the 2 4-chamber views next to each other just to show the difference within a week. So is so the RV is recovering. So so the condition was on to the second part of the presentation. The condition was premature closure of the arterial duct. This is a rare ductal abnormality. It is defined as a significant constriction or closure of the duct antenatally, with an absence of with no other structural heart abnormalities, because you can have them with other cardiac conditions. There are certain pathognomonic features. Obviously, you've got a right ventricle with a huge afterload antenatally, tricuspid regurgitation, right atrial dilatation, and right ventricular hypertrophy and dilatation. So in most cases are reported are because of NSAID use during pregnancy, but some are reported due to use of steroids. But there's a lot of idiopathic cases as well. And I thought that the pathophysiology is quite interesting. So with the premature closure of the PDA, we've got increase in the RV afterload, leading to RV dysfunction, dilatation, and hypertrophy, and severe tricuspid regurgitation in most reported cases. The other part of the equation is obviously the increase in the pulmonary tract pressures and the resultant changes in the vasculature of the lungs, which causes pulmonary hypertension. In some of the reports that I've read, the dilatation of the branch PAs is that big that it causes obstruction of the airways and air trapping, which can be evident in the chest X-rays. So in terms of echo findings, so right to left flow through the PFO, right atrial dilatation, right ventricular hypertrophy, dilatation and dysfunction, severe TR in most cases, various degrees of pulmonary regurgitation, as well as issues with the pulmonary valve, and obviously a closed duct within the first 24 hours of life. Interestingly, the clinical presentation can be very varied. It could be that you've got a baby on that's just been born with some respiratory distress that settles, all the way to severe constriction of the duct antenatally that causes fetal height drops and intrauterine death, as well as severe postnatal cases where it is required for the babies to have full ICU support up to ECMO that sometimes obviously can't resolve the situation, and some of the babies die. Treatment options, so delivery of the affected fetus is what resolves the issue, because with the opening up of the pulmonary vasculature, the pressures and the stress in the RV improves. But obviously there's the weighing of prematurity against the impact of the disease, as it usually happens. Postnatally, the therapy is the therapeutic options are supportive, so FI2, intubation, ventilation, inotropes, and pulmonary vasodilators, and obviously, as I mentioned, ECMO, all of which might sometimes not help, in which case the babies might die. In milder cases, the RV hypertrophy slowly improves and the function obviously normalizes. And in terms of learning points, so there were some clinical features that made us think that this is not just PPHN, and obviously we're always very aware of this. In the differential diagnosis, there are multiple cardiac conditions, TAPVD, but obviously we've just seen a rather rare one, which is the antenatal closure of the PDA, and obviously that case also outlines the importance of early cardiography, echocardiography, and discussion with the pediatric cardiology. At the end, just some resources. So Orphanet was the place that I found most about the premature closure of the arterial duct, and these are some interesting papers if anyone wants to have a little read about that. And I think that's it. Thank you very much for your time. It's probably time for discussion and questions.
Okay, so I had a look at participants. I cannot see any hands raised, but yes, just to anybody with the question and comment, please.
Can I maybe just start from the beginning and ask a question in general? Sure. I think one of the first slides that you presented was kind of typical what we sometimes see. Term baby, 40 weeks, 4 kilos and something, almost 80% of oxygen on non-invasive ventilation, receiving surfactant. And I found that uncomfortable as an approach. I don't know if it's something that is common practice, but we have been discussing these situations in past cases, and how often going down the route of, oh, it's RDS with a primary lack of surfactant could fit nicely with a preterm baby, but with a term baby, we always have to think about there's something else. That's the time to call the tertiary unit. more than the time to do a LISA, and it's probably the time to intubate. But I don't know if that's kind of a conversation to have as well, because it's such an interesting case from different point of view.
Yes, I guess hearing the handover from the transport team that night, it was something that we discussed at that point, that whether that baby need to be intubated and not have LISA, because subsequently, and obviously there was but it's difficult to know because we weren't there. It's difficult to know what the thinking was behind this. We do know that the X-ray showed just mild RDS. So maybe the hope was that the baby was going to improve, but I absolutely agree with your point. I don't know if Praveen wants anything else to say on that, or has anything else to say on that.
No, I agree with Anna that this was a baby, I think, from one of our level 2 units, and I think often when we have respiratory distress and we have a situation where we are not oxygenating, the practice tends to be, okay, let's intubate, get control of ventilation, and then surfactant seems to be, and LISA seems to be, I think, a commonly used and often abused procedure, because when we looked at the X-rays, we were not convinced that there was a lung pathology. And that was one of the reasons why I was on call on that night with Chrissa, and we were thinking, why is this baby in so much oxygen? Because the lungs look absolutely okay, and the PaO2s on all the gases was fine. So we were in 100% oxygen, but the PaO2s were absolutely okay. So that was something else that didn't make sense. And they had done an echo, and that was sort of, when someone does an echo and you've not seen the images, it's very difficult to comment on it. So they said, you've done an echo, there's a bidirectional shunt, there's a TR. So we thought, okay, fine, you might have a PPHN. But clearly when they came to us, we're not convinced that that was the case.
Yeah, very interesting, thank you. Mahmoud?
Yeah, thanks very much for this interesting case. Really very interesting and very nice images. I just wonder also, now we're kind of moving towards more precision medicine and personalized medicine rather than applying the protocols for every single baby. I wonder if the lung ultrasound would have had any additional value, because, you know, babies who have equivocal X-rays, sometimes you just do what we routinely do, intubate, ventilate, surfactant, etc. But then there is no response, so probably you just need to rethink what's actually going on differently. So maybe ultrasound at the start would have helped direct management.
Agree. I think we did have a few images when we did our echo. We did a lung ultrasound, and I think we were quite happy that it did not look abnormal. It was just a very normal lung ultrasound profile. So, yeah, and I agree that it could have changed the decision for whether or not surfactant was needed if it was available on the referring unit.
Yeah, but yeah, absolutely. But I just don't want to dismiss what has been done in the level 2 unit, because they have done exactly what should have been done. It's it's just adding the extra layer of knowledge that might sometimes help to refine the management. But it's exactly the same management you would do anywhere, anyway.
Agree. I was curious if any of you have been in this situation, because I've heard of PDAs being closed antenatally, but I haven't seen one presenting as a PPHN. And me and Chris were discussing, we've done a little bit of cardiology amongst us, and we were like, haven't seen one, but have you, any of you come across?
I haven't seen personally, but I've heard of, but maybe other colleagues on the call can give us some more insight. I think Zoltan has his hands up.
Yeah, we've seen one a couple of years ago, or at least it's a bit of a diagnosis of exclusion, isn't it? So my question is coming to that what's the literature definition when you can establish that, and what was the time of the echo when you did it. So, and the reason why we say it was probably, it was very likely to be a premature antenatally closed one, because it was just not open. And at what time you say, okay, it's not a black lung PPHM with muscle hypertrophy. So that's what I would like to ask. I don't know the literature data in this respect.
Yeah. So the definition, the definition for the condition I got from Orphanet. So I don't think, because there's not much in terms of literature out there about this condition, because it is very rare, and as you say, it's probably a condition of exclusion. I couldn't find an echocardiographic. I could find the pathognomonic features of it, as I've showed in the on the slides, but not a definition as such. I know that in most cases, I mean, most of the papers that I read talk about no duct within the first 24 hours of life. So if you scan within the first 24 hours of life, saying you find no duct, and obviously probably no other obstruction anywhere else, you think it is the duct. But that's the extent of what I know. As I said, as Praveen said, my personal experience with it is just antenatally, so basically, and babies go into hydrocephalus and die. I don't know if Praveen has any more insight on this.
Oh, yeah, the antenatal is easy to establish.
Yeah.
It should be open. No, it's not open.
Yeah.
All time, there is no doubt about that one. But this one, when it's like, we know that, I mean, it's kind of dynamic feature, and we know that maybe is 98 or 96% will close the duct in the first day of life, but some will close, within 6 hours. So if you do a scan 12 hours, 18 hours of life, that's why I was asking what time the scan was done. You got babies absolutely normal who already closed the duct. Obviously, if the pressure is high, the high pressure might keep the duct open longer. But I think that would be where to, we should have a clear picture in terms of when we can say that, okay, it is an antenatally closed duct, rather than just a black lung PPHM without much lung pathology on the X-ray, but there is muscle hypertrophy due to antenatal abnormal development of the muscle layer. Okay, that was it. So it's more just repeating my question rather than.
I don't know if Praveen has an answer on this. I think, as I said, for me, it's the constellation of pathognomonic features on the echo plus the absence of a duct. But yeah.
Zoltan, my feeling was that it's probably a spectrum. If you have closed your duct antenatally at 20 weeks, the baby is likely to have hydrops and die.
Absolutely.
So this most probably happened perinatally. It was interesting that the cardiologists, when we talked to the cardiologist, they said, ask mom if she's had any herbal tea. So that's another one of the causative, things. Herbal teas, don't know what they contain. And so that was one of the things. I felt that it must have been quite close to, around delivery. Again, I do feel it must have been on for at least a couple of weeks, because the heart, the RV looks very hypertrophied. Even
I agree.
in a situation of PPHN, you wouldn't see that sort of an hypertrophied heart. And if the PDA was open at birth, in such a situation, I wouldn't have expected it to close, because you have such high lung pressures, then it would have kept open. So
keep it open.
That's sort of my thinking about timeline, that probably a week or couple of weeks before delivery. And we're lucky that the baby came out in good time.
Ajay, you have a question?
Yeah, well, just a brief comment. I think, first of all, excellent case and beautiful videos, so very well done. Yeah, I do remember a few years back, we did have a case very similar to this. There was a history of regular aspirin use, certainly towards the end of pregnancy. And that baby, I don't think we needed multiple pulmonary vasodilators that you have needed to use, and did respond. We did, very similar presentation in terms of closed duct and right ventricular hypertrophy. And we did attribute it to premature closure of ductus. Yeah. So, I'm sure, I think this is perhaps maybe not as commonly recognized, or perhaps is certainly a rare condition, but maybe some of those which presents maybe as not as commonly recognized.
So maybe some of the black lung PPA gens are actually premature closure of the duct.
Possibly.
Some of those most of them wouldn't do any harm with it, just if they adjust a bit and if the cough isn't improving.
Anna, are you asking a question?
Yeah, sorry, I could hear somebody in the background, so I thought it was another question. Just in one of the slides, you were mentioning a reverse differential in the saturation, and you thought there was an interesting point. It is. Tell me about it.
Yes, true. So, so it was. So it's one of those situations where you unplug the saturation probes, make sure that you're seeing what you're seeing. Yeah. So that's what we did, and it was definitely so. Our post-ductal saturations were higher than the pre, and we did have a discussion with the transport team at that point because they'd not left the unit by then, to ask what they experienced there, and then they said, "Oh, we had differential saturations and then the rest of it." So I think, and then we discussed the point with the pediatric cardiologist, and they said, "We can't really explain this. It could be that it is a perfusion issue, and without the duct, you can't really have differential cyanosis." And then when we saw the X-ray, the UAC was curled into the aorta. So I don't know if that was contributing to what we were seeing, but it couldn't really be explained with what we had in front of us. And the cardiologist also said, we can't really, it's probably a perfusion issue more than anything else.
Yeah, they had a very interesting comment saying, yeah, we see that sometimes, and we never really have an answer. But don't worry, the duct's closed, so it's not of any significance. We thought about it a lot because there was a significant gap, and it was definitely reversed, and we just couldn't make sense of it. I don't know if it was right to left shunting, but still, that wouldn't explain it completely.
Okay.
You're muted, Ajay.
Yeah, you often get a call of pre and a post-ductal saturation difference, and wrong way around, as in this case, and 99 times is going to be probably not appropriate application, and therefore the trace that you are getting is considerably poorer from pre-ductal part as opposed to the post-ductal part. I think that's right. I mean, theoretically, you can think of and I do remember seeing one case of a TGA with the left ventricle, left outflow tract obstruction, and there you can think of your pre-ductal part of the aorta having a desaturated blood, and the post-ductal part which having a higher, but how likely is that condition to happen? So I guess that's not something that we're likely to be seeing not more than once in a lifetime, perhaps.
Yeah, it's very interesting. We've got some comments from Aaron, our friend from Manchester St. Mary's. So Aaron, that was a case of premature closure of PD. I don't know if you had come across one of those before.
Not really, but I guess I was just wondering, there were no MAPCAs. I came a bit late. I'm so sorry. I didn't look at the echo, but sometimes if you have MAPCAs, because that would serve as a conduit between the systemic circulation and the pulmonary circulation, you can still probably have some kind of differential saturations. But I'm sure there was none because it was obviously discussed with the cardiologist.
Yeah, is a very rare case. I think you probably need to write this as a case report. So yeah, interesting one. Thank you.
Okay, so if there's nobody else, can I ask a question, Praveen? I admit I haven't personally seen a case like this. So my question is a question. It's not a comment. I'm just asking you. So it's in its initial management up till stabilization. I understand. By using the scanner, I would have avoided surfactant because ultrasound is really good to guide me in that. So fine, up to surfactant, the difference in management, I can understand. I would have handled this. But other than that, how does the management here differ from any other bad PPHN management? The initial bit I'm saying up to stabilization. I know for the structural change, the hypertrophy and stuff would have needed some medication for a longer time. But I'm talking about the initial period when the baby was in level 2 and was being transferred. So apart from surfactant that I would not have done, other than that, I mean, that what they did was the right thing to do. So so what are your comments on this? Thank you.
I feel that within their abilities, they probably did everything right. The function of the right ventricle did look quite poor when we had a look. And the choice of inotropes may have been something that we might have talked about. We were on dobutamine and adrenaline. We had good blood pressures. So we were thinking of milrinone before we had talked to cardiology because there was significant RV dysfunction. And even if there was no closure of duct, we would still have thought about milrinone with the cover of, adrenaline, noradrenaline, and slowly get one of them. I wouldn't use dobutamine. That's my personal sort of opinion. I do not know what the rest of the people here would feel. That was the only other thing, but I feel everything else, they intubated, gave antibiotics, they did an echo, and they probably couldn't find the duct, and they didn't feel confident that it's not there, because even we didn't feel confident that it's not there. Me and Chrysa were saying, we can't see it, maybe we can't see it, maybe it's completely reversed. So I think they did everything right, apart from the choice of inotropes, which again, it was difficult to say because I don't know what the function was at that point. We are talking about a baby who was like 8 hours later, we had seen them. I think I agree that they.
So you feel milrinone and adrenaline could be your choice rather than dobutamine and adrenaline.
I felt that once I had good blood pressures and if I had seen RV dysfunction on the echo, that I would want to improve the RV dysfunction, because we wouldn't win just with nitric and 100% oxygen. And if we got in a situation where the RV function started improving, you would see, if it was just plain pulmonary hypertension, you'd see improvement, and then you would be able to get off whatever initial inotropes you were on. So apart from that, I can't see any other changes I would do.
Yeah, if I can just
great. Thank you.
So I suppose the milrinone has advantage over dobutamine, particularly if you have a reasonable systolic blood pressure, is that it's also pulmonary vasodilator. So not only will support the RV, but also will help the pulmonary hypertension to come down. But again, it's personal choice, if you like. Different units manage that differently, as we all know. And some units are not comfortable to use milrinone. So I think you use what you can use in your unit and make sure that you use it in a safe way, probably.
Yeah, I mean, I'm under the impression that milrinone comes in as an adjunct, an improved situation, but as an adjunct. So is this a rare and unusual situation where you would bring it as the first one?
If we had robust blood pressure, systolic, and if I saw very poor RV function contributing to it, I think yes, there was a situation where we could have used milrinone to help with getting the RV functioning better.
Okay, great, thank you.
Anna?
Yeah, no, just gonna say the same thing. We had 2 cases, one non-natally and one postnatally detected. And yeah, the first approach is mirroring place, because what that right ventricular dysfunction is so marked. So I think it's one of those rare conditions, but at least we know how to approach it by reducing the pulmonary vascular resistance and supporting the right ventricle. I don't know if by the time of the referral and transfer, if you had any signs of impaired systemic perfusion already, that maybe they made it think about adrenaline. I don't know, because the initial lactate was 4, but on the cord gas, so I mean, kind of normal. But I don't know if there was already a trend that worried them from the point of view of systemic perfusion and need to support the left ventricle for some before the diagnosis. You know, it's difficult.
I agree, Anna. I can't remember now. Chrysoula has gone through the notes, so she might be able to tell us.
So I think the thinking, when the baby was still in the level 2 neonatal unit and we were giving them advice, we were working on diagnosis of PPHN, so they were trying to aim for higher systemic systolic blood pressures. And that was, so they never had perfusion issues, the lactate never went off, but the adrenaline was started just as a low dose to maintain good systemic blood pressures. And it was a low dose adrenaline as well. It wasn't a big one.
Yeah, I guess it's easy when you have the diagnosis, isn't it?
Great. So I cannot see any hands raised, but there was such a wonderful case sharing and presentation. And we have time. Is there anybody else who would like to share any wisdom on this?
We have Dr.
Okay,
Simon
so in
Clark
that
with us. Good to see you, Simon. And we've got many friends on the call as well. So any final comments before we leave? Okay. That's great. So over to you, Ahmed.
Okay, then we could call it a day, Mahmood. Then so Praveen and Chrysoula, thank you so much. It was an amazing case and a wonderful discussion. So hoping to see you all next week then. Take care. Bye-bye.
Thank you, everyone.
Thank you.
Thank you, everyone.
Well done.
Bye.
Really nice case.
Bye.
Yeah, absolutely. Super case. Absolutely.